So, hello everyone. I think everyone's busy. I'm standing straighten their legs. Yeah. So next up is of course Dr. Karen Gadoo. And just before the break, Karen, we were talking, and some questions in the Q&A were about communication, which we've just covered, and future research, etc. into the future. And so, Dr. Gadoo, I hope I can do you justice by reading all of this now. You don't need to read Well, we'll read most of it. You can fill in the blanks. So, Dr. Gadoo is a cancer geneticist and medical oncologist at St. James's Hospital and clinical associate professor at Trinity College Dublin. She co-leads the Inherited Cancer Genetics Program at St. James's and the Cancer Prevention Pillar of the Trinity St. James's Cancer Institute. A mouthful. Very good. She serves on the National Cancer Control Program, the NCCP, Hereditary Cancer Oversight Group, and participates in the NCCP committees to address the needs of patients with inherited cancer predisposition. As a member of the NCCP Advisory Group for Cancer Genetics and Genomics in Ireland, she has contributed to the National Genetics and Genomics Strategy 2022. Her research focuses on inherited cancer genetics, the interplay with tumor biology, and potential opportunities for cancer prevention and risk reduction. She has explored the role of inherited cancer predisposition in gynecological cancers and across multiple cancer types. She is a recipient of the Irish Cancer Society 2021 Clinician Research Leadership Award for her research in hereditary cancer genetics. She has also served as principal investigator for multiple therapeutic trials in ovarian cancer, served as a member of the NRG Oncology Ovarian Cancer Committee, and is Clinical Trials Ireland representative to the European Networks of Gynecological Oncology Trials Groups. Do you sleep? That's fantastic. Come up here, Karen.
Thank you.
And you can take a chair if you feel or stand up. Yeah, so you can see the topic that Karen's about to discuss.
Thank you. And you asked me that.
Are you okay or not okay?
Yeah, I'm okay.
So
Yeah,
I'm okay to.
Yeah, thank you. And thank you very much for having me here. And I'm sorry that I wasn't able to be here for the whole day, but great to get the end of that last discussion, which was really fantastic. And hopefully it's been a brilliant day so far. It's everyone has. So here are my financial disclosures, and what I was just going to talk to you about today is what the future might hold, partly based on where we've got to so far and what we might be looking at. But of course, you know, some of the things that we work on never come to pass, and many things happen that we never anticipate. So there will be great things will happen in the future, and we're talking sort of over the next 30 years. So some things we haven't even thought of. And what I included at the bottom here is that, and you know, you've heard now the introduction, I'm a gynae medical oncologist primarily. So I started doing, when I started as a consultant, I did women's health, I did breast and gynae cancers initially, and now I do gynae only. And so a lot of times when I talk, thank you very much, I talk through the perspective or the lens of ovarian cancer. And I kind of do that on purpose. And it's not to take away from breast cancer, but from a kind of public awareness point of view, breast cancer gets a lot more press. And from gynae medical oncology perspective, ovarian cancer, as we all know, can be a very challenging disease, and there's a lot of work to be done in this space. So although this talk is somewhat focused on ovarian cancer, the principles really apply to other cancers as well, but just to give you that kind of framework for how I'm going to speak. And for anyone who's seen me speak before, I often use this slide to frame what we're going to talk about, because this is how I think about genetics and cancer and how they come together. So when we think about cancer genetics, and what we're talking about here today, of course, is inherited cancer genetics, because it's a bit of a complex world when we get into the tumor space sometimes. But what's the chance of getting a cancer? And if we have that information, what can we do about it? And if you unfortunately have a cancer diagnosis, might genetic information be important in terms of your cancer, in terms of what we understand about it, but also in terms of what we might do about it? And then if you have a cancer diagnosis, might you have future cancer risk? What can we do about that? And then of course, what about your family members, and back to the question of risk based reduction. And so really this is what we're going to talk about today, where we kind of might be right now, but where we are going hopefully into the future. And from my point of view, and I suppose in this room, I'm kind of preaching to the choir, because you guys understand the importance of germline genetic information, which, you know, for some audiences, perhaps it's trying to convince them. of how valuable it is. But germline genetic information provides opportunity for risk identification and for risk reduction. And it's so important in multiple cancer types. And we now understand this so much better. And this has really facilitated wider access to genetic testing for people. And I think that's really important as well. So if we start about cancer risk, what's the chance of getting a cancer if you've got a BRCA pathogenic variant? We try not to use the term mutation anymore in terms of germline genetics, we use the term pathogenic variant. So we know this, that your risk, unfortunately, of getting ovarian cancer is about 20 to 40%. And for breast cancer, lifetime risk roughly about 70%. And those numbers are somewhat informative because they tell you that there's an issue and that you might need to do something about it. But it'd be really better if we could be more precise about those numbers. If we could be more precise for a given individual, as opposed to telling you what a group of women have experienced. And we have made some progress in this space. So we now use the CanRisk algorithm quite a lot. So CanRisk is based on data from many patients and feeding in not just genetic information, but also other information like lifestyle factors, hormonal reproductive factors, and family history, not just the genetic information, but the family history in addition to the genetic information. And this is useful because it can provide a lifetime risk, but what's also can be important for women, especially young women who are trying to make decisions, is for a 5 or 10 year risk. So this is for a patient, just to give you an illustration of how this might be useful. So this is someone's ovarian cancer risk, and as you can see, her risk, unfortunately, that blue line is a little bit above that dotted line. So her risk of ovarian cancer in her lifetime to the age of 80 is roughly about 40%. This woman had a lot going on in terms of other healthcare issues, so trying to make decisions and prioritization. What we were trying to help her understand is when was her risk of ovarian cancer going up and when did she need to do something about it? And so I put an arrow there at the age of 39. So the population risk of ovarian cancer is about 1.5%. She was crossing the population risk at the age of 39. And she was crossing the kind of what we would call first degree relative threshold is about 2.5 to 3%. She's crossing that at the age of 40. Now, our general recommendation, you know, with BRCA, one is risk reducing surgery at the age of 35 to 40, but that's doesn't always work out depending on what other things are going on in someone's life. And then when you're trying to make the decision, well, do I really need to prioritize that risk reducing surgery, or can I put that off for a little while because I have all this other medical stuff going on? Well, for this lady, we have to say, unfortunately, the numbers suggest her risk of going up relatively soon. And so I think that needs to come forward in the prioritization. But this is helpful if we can be more precise. Because of course it is all about risk management and making those decisions, and really those decisions are not just about what you will do, but about when you will do it. And so when we think about risk management, options of course depend partially on the disease. And this is Chris Everett, you might recognize her, she's a famous talent sprayer whose sister unfortunately had ovarian cancer, and this led to her finding out that she had a BRCA pathogenic variant. And, you know, this is where I start thinking about ovarian cancer, or, you know, we talk about ovarian cancer and compare that to breast cancer, and it's a slightly different conversation. So unfortunately, there is no successful screening for ovarian cancer. And that is hugely challenging because we say that even in high-risk women that doing screening isn't the answer. And the real question is, why does it not work? Because if we had screening for ovarian cancer, then some of our decisions may be more straightforward or easier to live with, I suppose. So the issue is that we now understand that high-grade serous ovarian cancer, so when we think about BRCA, we're talking about there's different kinds of ovarian cancer. And when we think about BRCA, we're thinking about high-grade serous ovarian cancer. High-grade serous ovarian cancer, we now understand, and relatively recently understand, that it rises most likely within the fallopian tube, which sits on top of the ovary. The cell either grows in the tube or drops out onto the ovary or into the space and grows in the peritoneal space. So when you do a transvaginal ultrasound or CA125, really what you're looking at, when you're doing an ultrasound, you're looking at outside the tube, and you're not going to find something inside the tube. And it's trying to find something before it's dropping out and taking hold. If it's making CA125, it's probably already dropped out. And if it's something you can see in an ultrasound, well then that's not picking it up early. And that's our real challenge here. So as you know, this leaves us with risk-reducing surgery, which is removing the ovaries in the fallopian tubes. And as I said, we recommend this standardly for women with BRCA pathogenic variant BRCA 1 35 to 40. So we standardly make a generalized recommendation for all women with the same variant, as in the variant of the same gene, but that's not the same variant, right? And then BRCA2, 40 to 45. So I'm going to talk to you a little bit more now about where we're going in the future in a moment, but just to kind of talk about breast cancer for a moment. I think we all think about, when we think about Angelina Jolie, she really was public about her breast cancer and ovarian cancer surgery, but I think what kind of got picked up a bit more was the risk-reducing mastectomy. So when we think about risk management in breast cancer, we have that option for risk-reducing mastectomy versus the option for screening. So mammograms and MRIs, although for those of you guys who've experienced breast MRIs, they're usually done prone, I think, so I'm not sure. I wrote down my slides and I never stopped. It's like I could send you new work, which is, it's not very educational. Because I actually Googled just breast MRI, stuck a picture in it. Anyway, so, but, surveillance exists. And of course, for individual women, it's making a decision between whether they're comfortable with surveillance and the fact that they might get a breast cancer diagnosis. Yes, with the anticipation is you pick it up early at a stage that's more amenable to cure with less therapy, hopefully. But the prospect of a diagnosis at all, are you okay with that? And whether risk-reducing surgery may be a better option, but it's a conversation and there is some agency in it. It's not real choice. If you had real choice, you wouldn't be in the situation in the first place. But in comparison to how we talk to women about the ovarian cancer risk, it is a slightly different situation. So when we think as well about catching it at an earlier stage, it's actually very important to know that you've got a BRCA pathogenic variant, ideally important if possible, of course not always possible, but at an earlier age so you can plan. So Chris Everett, she went public, and you guys may not be familiar with this story, this is more known in America. She was 67 when her sister, when she had a BRCA test, and she was diagnosed with BRCA1 pathogenic variant, she had risk-reducing oophorectomy. And at that oophorectomy, she had a stage 1 ovarian cancer. One of the big problems with high-grade stage ovarian cancer is because there's no screening, we often don't, most often, when people are diagnosed, they have advanced disease at stage 3 or 4 diagnosis. 80% of women, unfortunately, 70 to 80% of women with high-grade stage ovarian cancer have stage 3 or 4 disease. It's very difficult to pick it up with stage 1 in the current era. I'm going to tell you about what's coming from that maybe. So she had risk-reducing surgery. That is the scenario in which you can have a stage 1 diagnosis, and she had chemotherapy. She still need chemotherapy for a millimetre of high-grade stage ovarian cancer with chemotherapy, but she's almost certainly cured of her disease, thankfully. So what we now know is that your age at risk-reducing surgery matters. So this is a study of about 2,500 women. The risk of finding an incidental ovarian cancer when you have risk-reduced surgery is extraordinarily small overall. It's about 1.2%. So it is small, but that's about 1 in 100 women have an ovarian cancer diagnosed after risk-reducing surgery. The issue, though, is if you look at that BRCA1, it goes up if you have that BRCA1 over BRCA2, partly because we know BRCA1 associated ovarian cancers occur younger. And this is really driven by older women having risk-reducing surgery. So if you have your risk-reducing surgery done at the currently recommended age, there's a 0.4% chance of you having ovarian cancer. So that's all well and good, but you have to know you've got a BRCA pathogenic variant to be able to have surgery at the recommended age of the start point, right? And that's where awareness is so important. And I'm including these pictures because these are from the New York Times, which is, popular or general media, right? This is a niche science. And so what's been so important one of the biggest things that's happened, honestly, over the last 5 years in some ways in this space is people talking about this. And, coming here today, having a conversation about it. In Ireland in particular, we've been very reticent to talk directly about our healthcare. I worked in New York for 8 years and people are much more direct about their healthcare. It's a different world, much more direct about most things. But we have to have a conversation where this is routine. It's just part of the day-to-day, the same as any other thing in your life. And that changes the world. So Chris Everett was 67 when she found out she had a BRCA pathogenic variant and she had a risk-reducing surgery with an ovarian cancer diagnosis. Angelina Jolie was 38 because of all that her mother went through, but she had risk-reducing surgery and no cancer that I know of, to be fair, we don't know it, but most likely and hopefully will be well. And I think it's so important to acknowledge what a massive thing at the time that Angelina Jolie went forward publicly, really people haven't done that. And she really did change things, but we still have a lot of work to do in that space. And I think it's so important just to acknowledge that and to recognize the importance of making something familiar as part of the day-to-day, right? So it's important not to forget about the men. So Beyonce's dad, Caitríona, went public with his breast cancer diagnosis, which is challenging too, right? So he's got a very famous daughter, and he has a BRCA2 pathogenic variant. So it's important not to forget about the men in general, but also I think this is really important to remind men that testing can be important, not just for them, but for their family members. It's one of the things we struggle with a little bit here in Ireland is the engagement of older men in the healthcare system. And unfortunately, you know, the best person to test in the family could be a man, and he may not be willing. But again, if it's more day-to-day conversation, and if we talk to men about this and make it more normal, well, then they might be more willing. And it is so important for the people in the family, potentially not just their own healthcare, because they can say, anyone can say, I don't care for my own healthcare, I'm not going to do anything about it. And they're entitled to make that decision. People make decisions all the time that we don't necessarily agree with. But what we really want is to encourage them to think about it in the context of their wider family as well. So what can we do better? What will we do better in the future? What are we already doing better? We've made some good progress, but it has to be better than this, right? So one of the things I showed you about CAN risk, where we can make maybe more precise estimates for women in terms of breast cancer risk. I didn't show you breast cancer, I showed you your ovarian cancer, the same in terms of your absolute risk, your timing risk, and short and long-term risk. Well, polygenic risk is also coming to the fore. So everyone has these small changes in their genes. They're called single nucleotide polymorphisms, or SNPs we call them. And each one of those in of itself may not be that important. Their chance of changing, or they change the magnitude of you getting cancer potentially by a very small amount. So 1.1, something like that, is not that meaningful. If you put them together into a score, if you put a number of SNPs together into a score, they can be more important. And what can be useful is this is a study that showed for women with a BRCA pathogenic variant, looking at the risk and the timing of risk in a more individualized way. And so this is really important. The CAN risk is doing some of it and is sort of achieving that to a certain degree, but going forward, this will be much more important. If you put together with the likes of some of the things that go into CAN risk, like lifestyle and hormonal factors, and your polygenic risk data, well, then you might be able to really make more precise timing. Because what we're going to talk about, of course, is in terms of surgery, the surgery itself, having bilateral sublingual oophorectomy, is a relatively small procedure. Of course, the issue is menopause. We all know that, right? So if you look at these circles, I don't know how well they project actually, but basically, if you've got a BRCA pathogenic variant, BRCA1, they're saying, so instead of us saying you need your ovaries taken out between the ages of 35 and 40, well, maybe you could wait to 44, 45, or 48, depending on what your polygenic risk is and what your comfort level of risk in your score is, right? So depending on what threshold of risk you're going to intervene at. So if you could hang on to your ovaries till you were 48, that would make a massive difference to you versus having your ovaries taken out at 35 or 38, both in terms of your health, but in terms of your quality of life, of course, as well. But, you know, there's a lot of work to be done to kind of finesse this a little bit better. And there is a piece to it too about thresholds of risk and what people are comfortable with, because we never can say no to this, right? But we also might understand, I showed you 0.4% of people who have risk reducing surgery at an appropriate or recommended, still having an incidental cancer plan. So those are women who should be recommended to have surgery younger than our current recommendations. And that's important too, right? Because if you knew your risk was going to be super young, well, then you would do something about it soon. Because one of the things that we have to factor in, I should have said this when I was talking about the risk reducing surgery thing, is that stick or the pre-incursor lesion, which is like a DCIS, might be what you'd be more familiar with in the breast, the equivalent to the ovaries, a stick lesion, that drops out probably 3 to 5 years before a diagnosis. So you want to get your fallopian tubes at least out, and we'll talk about that too, in advance of that stick dropping out, because, you know, if you do, that's the whole thing of the risk reducing surgery, that the cells are already there at the time that you've done it. So you need to do it in advance. But this, I think, could be really useful in terms of being more specific to people, both in terms of their absolute risk and in terms of the timing of the risk. The absolute risk in some ways is less useful because, you know, if the population risk of ovarian cancer, for example, is 1.5%, if your risk is 6%, that's still quite high relative to population risk, and higher than we find acceptable in the context of an ovarian cancer diagnosis. And if your risk is 15%, it's still too high, and if it's 20%, it's still too high. You still need to do something about it no matter what. So actual risk in some ways, the numbers may matter to an individual person, and I'm sure they do. But what really I think matters most in a meaningful way in terms of what you're going to do about it is that timing piece and making decisions relative to your current age potentially. So the next question is, what about the surgery options? Can we do better there? And you guys, if people are familiar with this world, you've probably heard about this question of self-injecting with delayed oophorectomy. So that means because we now recognize that these precursor lesions are derived from the fallopian tube, can you take the tubes out and leave the ovaries in place until older? And, you know, with that, maintain hormonal function, of course. And so there's a lot of research in this space, and currently it's not recommended outside of a clinical trial. It may well be in the future that this is where we go. But this is the tube-of-whisk protocol. I just want to give you a sense, and this is based on a couple of clinical trials that have gone already, which have been mainly looking at quality of life outcomes. Unsurprisingly, if you hang on to your ovaries for over your quality of life is fine. That's an easy answer. The question is, what's your sort of outcomes? And that information is not available yet. I've just included this to show you what the timeline here is. They started accrual in 2021. They expect to have it completed in 2026 and expect to have data in 2036. So it takes some time to get outcome data, right? So, you know, that just gives you a flavor of what we're kind of dealing with here. And the other thing I wanted to highlight is what they're talking about is shifting the age of doing surgery for BRCA 1 to 40 to 45. That's delayed 40 to 45 from 35 to 40. It's not delayed forever. And then for BRCA 2 also shifting 5 years. The question then, when we get the outcome from this, if this is safe, well, then you might be able to incorporate, for example, those polygenic risk scores, get a specific age for a specific individual, and then say, well, you can take your tubes out up to this point, and then at that point, you need your ovaries out. Maybe that's where we're going, right? That could be really valuable. I think the data from this would be really important, but I can't stress enough that we do not have safety data from doing tubectomies yet. In the United States, it's relatively commonly done in the general population, not the general population, just in community oncology practices. And I think it makes me a little edgy, frankly. Yeah, the biology is good, and yeah, it might work. But until we know that, you know, you are playing a little jeopardy there. So just to touch on the menopause for a second, I'm not going to talk about it a lot, but of course, as we all know, this is such a challenge. And I think this is kind of what I was talking about with the kind of awareness about BRCA. Menopause is now becoming part of the day-to-day conversation, and that's so important. And what's so important is to get some actual data. This is not really being all that well studied, honestly. So this, Martha Hickey presented at the ISGO meeting last November, a really great presentation. But what she did was spoke to women or surveyed women before they had this risk-reducing surgery and afterwards. And what's so important about that is to get actual specific information, because some women have quite a lot of symptoms before they have their surgery. And so what you do with those symptoms depends on what you think is causing them. And if they had the symptoms before they had their ovaries out, well, they weren't necessarily driven by hormonal mechanisms, right? So I think it's just so important that we're getting some more information in the space, and that will drive better opportunities to intervene and better resources as well. So I just wanted to include, there was this menopause after cancer study being done by UCD. It's completed accrual now, but this was a combination of app, cognitive behavioral therapy app, and some therapy for hot flashes. There is a lot going on in this space, but like, it's great to see this study done. We'll get outcomes from this, and more studies are also going on. New agents for hot flashes, non-hormonal agents, for example. I'm just not getting into the HRT space, I'm just letting you know. But that's a complex space, but I'm just saying there's the HRT space, and then there's better things to be done in the non-hormonal space, because HRT is not available to everybody, again, people would know. So, for example, we just opened a trial in St. James's, or just about to open for women who have a breast cancer diagnosis who are not eligible for HRT for medication for hot flashes as a non-hormonal therapy. And even though that study actually isn't available to high risk, like BRCA cohort, which at one stage I thought it was going to be, I thought it would be great, it's not, but there is lots and lots of data coming in that space and more options, and that will be brilliant. And the other thing, I suppose, just to highlight as well, is the recognition of cognitive behavioral therapy in the space, which has been relatively recent, and we really do need more data to really support or drive resources, because cognitive behavioral therapy is not very widely available, but it is endorsed by the British Menopause Society for insomnia, for hot flashes, for anxiety, and there's not really data for sexual function currently, but there's no reason to suggest that I mightn't work in that space too with better data. So a lot of work going on and a lot of promise. But the other question is, could we have screening in the future? Just because there's no screening now doesn't mean that we can't have screening in the future, right? And that might be a great opportunity too. I just include this to give you like a flavour of there's lots going on. I'm not going to talk about all these things. But for example, I quite like this example. So this is uterine lavage. So like doing a hysteroscopy. So if you wash fluid up into the uterus, up into the fallopian tubes, pull that fluid back down and look for certain signatures, you may identify abnormal cells there. And that really might work quite well. So getting around the problem that it's inside the tube in comparison to the other ultrasounds in the outside the tube, right? So that's something that might be important in the future. So unfortunately, I sent you an old version of the slides that doesn't have an update, but I had put a picture in that you didn't get about pancreas cancer screening. So we understand there can be a small risk of pancreas cancer with BRCA2 in the context of family history of pancreas cancer. For years, we said there was no screening for pancreas cancer. And what I put in was just to give you a flavor of how long it can take from about 2000, there have been ongoing studies, 2005. And really, it's only in 2020 or so that we had data to support doing pancreas cancer screening. So it can take a long time, but we get there over time. And you know, there's a recent study that showed that the pickup rate for pancreas cancer at stage 1 was actually quite high. So you're trying to avoid a stage 3 or 4 pancreas cancer. Another challenging disease is difficult to pick up early. So what might also hold promise is circulating tumor DNA. So this was presented at ESMO last year. So this actually cell-free DNA is really what it is. So little pieces or fragments that can separate out into the bloodstream. And people may be more familiar with this from the prenatal testing. So women sometimes have, I think it's called Harmony in this country, where they have non-invasive prenatal testing looking for things like Down syndrome. Well, similar concept, you can look for small fragments of cell-free DNA. And what they presented at ESMO this year was really quite groundbreaking, looking at about 6,000 people, and they detected a signal or abnormal something that needs to be followed up in about 90 patients, and about 30 or so of them had a cancer they didn't know. So that has come a long way from where it started. We looked at cell-free DNA in ovarian cancer about 5 or so years ago, and it was very difficult. And it still has a long way to go though. So if you think about, say, roughly 90 people had a signal and about 30 people had a cancer, there's about 60 people who went through all that anxiety and workup who didn't have a cancer diagnosis. That's number one. But also can it pick up with this sort of sensitivity and specificity that we need? And the answer is probably not right now, but hopefully into the future, this really could go somewhere. And where this could be really useful is where instead of, for example, having your mammogram and having your uterine lavage, if that's what we're doing for our own cancer screening, and having your pancreas cancer screening if you're from a family where that's relevant, well, maybe you could just do a blood test once a year or once every 6 months, and that would do all of that for you. And that's really quite promising and probably quite realistic in the next, I don't know how many years, but definitely possible. The thing to just highlight about that though is screening picks up cancers at a pre-invasive or earlier stage is the goal, that you can have them cured with less therapy. It doesn't prevent cancer really, right? So for some people, having a cancer diagnosis at all is not something that they can live with. And so there will still be a role for doing risk-reducing surgeries, I think. And again, that's where we come back to, for example, with ovarian cancer, the timing of that risk-reducing surgery, the managing of menopause if you don't need to have surgery, for example, at 48, or if you do need to have surgery at 38, well, how do we manage the aftermath for that? So a lot of progress in that space. And then modifiable risk factors. So Sarah, I didn't know you were going to be here, but you're fine. So Sarah did a study which I find really interesting. And again, we're going to miss a few slides now coming up. We're going to get some blank slides in. But this is such an important piece from my point of view. So we cannot change our genes, but we can change what we do about it. We have information, it's very powerful. That's where we go for MRIs. We can have risk-reducing surgery. But what else can we do? Well, maintaining a healthy diet and body weight are so important. And there's probably a lot more that we can do in this space. So what I was going to put in here that's not here is, if you think about breast cancer in general, not BRCA associated breast cancer, but breast cancer in general, drinking, smoking and being overweight and not exercising can dramatically increase your chance of having breast cancer for women who are say between the ages of 50 and 59. So if they exercise for 2.5 hours a week, that reduces their breast cancer risk. If you have X number of alcohol glasses a week, then that increases your breast cancer risk, the same as being overweight. And I think that this is an opportunity that we really could do something about right now. So one of the things I would do though is separate out diet, exercise, and body weight, because I don't see them as all connected. So I think exercise is important whether or not your body weight is up or down. It doesn't matter, you still need to exercise. And your diet actually matters no matter what size you are. So one of the things that we're learning a lot more about is the quality of your diet, and probably to do with the gut microbiome. I don't know if you're familiar with this, all the bugs that you have in your microbiome that are working so hard for you, that are helping to reduce inflammation and manage your health. Well, they need things like fiber, for example. So you need micronutrients and you need fiber, because you can be thin and be micronutrient depleted. You can be obese and you can be micronutrient depleted, right? So it's all about managing. You need to have exercise in your life. You need a healthy diet that hits all the nutrients, especially with fiber intake. And then your BMI is maintaining a healthy body weight is challenging for many people. But if you do the first two, the third might come over time, over a long time. But also not to be disheartened, because if people focus on weight, then they might drop the exercise and diet, right? Whereas if you separate them out, the exercise and diet are important, and if weight comes, great. And then maybe focus on that slightly separately. So these are things that we can do a lot about, but I think we'll really learn much more in the next 5-10 years about how we can modify risk in this space for people in the general population, but if you have increased risk in particular. And so one of the things that I also was going to include, it's not going to be in these slides, was there's a recent study in obese women with BRCA pathogenic variants and how there was damage to the breast epithelium in comparison to people with normal body weight. And I think that's a really important message to get out there. So the other question is, what if you have a cancer diagnosis? What does that mean? I think we might be done in time though. Do you want to
We started too late.
Yeah,
okay.
whatever anyone
Really
said,
good
if you want.
information.
Yeah.
Okay.
Yeah, I'll keep going. As people probably getting tired of this stage. So if you already have a cancer diagnosis, what does that mean for you? And this space is changing too. So I'm just going to scoot through this real quick. I had included about tumor genes versus your own genes. You guys are kind of in your own gene space and much more familiar, but sometimes for patients, if they have a BRCA pathogenic variant in their tumor, it has nothing to do with them or the family members in terms of future cancer risk. So what we think about though is prognosis, which is usually kind of what is my outcome going to be, and then predicting, which is anticipating the likely benefit from therapy. And so sometimes they're intertwined. We've really learned a lot about this over the last little while, and we're learning more, and this is really important as well. So if you have a BRCA pathogenic variant and you have an ovarian cancer diagnosis, BRCA1 is that top line, and then BRCA2, and then other genes, your outcome is better than if you have no pathogenic variant. So that's the biology of the cancer firstly. And understanding that is important because it can affect what we do. Because we also see that in pancreas cancer. If you've got a pathogenic variant, that's the top line, you do better than if you don't. So this is in the context of having a cancer diagnosis. Unfortunately though, in prostate cancer, that's not the case. And this is where it's really interesting, because we've only learned quite recently, this study was in 2016, we've only learned quite recently really more about the role of BRCA and other HRD pathway genes in prostate cancer. And one of the things that might be important here is this predictive piece. So in ovarian cancer, we use platinums, that's the kind of the go-to or the backbone of chemotherapy. In pancreas cancer, we use platinums. They'll also be the go-to for a long time. In breast cancer, we only started using platinums relatively recent for certain types of breast cancer, and that may be very important in the BRCA space. But in prostate cancer, we've never used platinum. And so predicting, knowing what therapies matter, so outcome might be partly because of the therapy you get. So if we understand better why a prostate cancer behaves in a certain way, we might change the therapy we do, and that actually may change the outcome. So where some of this has changed is these PARP inhibitors, poly-ADP ribose polymerase inhibitors. So these are now used in prostate cancer, and these are more like platinums. So if you introduce a therapy that's properly targeting the vulnerability of the cancer, well, then that might improve your outcomes. So we'll see how the space goes over time. Our BRCA-associated prostate cancer is biologically more aggressive, did we just use a therapy that didn't work so well in that space? And if we change our therapy approach, maybe we'll equalize it over time. So this is why it's so important to really understand the biology of the cancer and what's driving it, because it can drive our therapies. So what we got a couple of years ago was this data from ovarian cancer. So for women who have an advanced ovarian cancer, surgery and chemotherapy was followed by olaparib, which is PARP inhibitor, for 2 years versus placebo. 50% of them were disease-free 5 years later, right? So they had PARP inhibitor for 2 years and at 5 years of disease-free. And if you look at the placebo curve, 20% disease-free, that is the cure rate of advanced ovarian cancer historically. So we have changed the number of people who are disease-free at 5 years, and this is really spectacular data. And there was actually then a follow-up last year that showed this persists out at 7 years, and we're really looking over time to see where we get here. There's been a lot of progress also in breast, prostate, and pancreas cancer with these PARP inhibitors. The curves are different, so the top line is better always, and the top line is a PARP inhibitor in all these, except for prostate, which is separating out the biomarker group. But basically, if you have a PARP inhibitor targeting the biology, then you do better from a cancer point of view. And where this is going into the future then is if we move it earlier in the disease space, well, maybe that would be better. So if you could cure breast cancer up front and not be in the advanced breast cancer space, if you put your PARP inhibitor into the upfront setting, well, then maybe we cure more people. And that's really what we're looking at now. So improving our approaches, understand the biology better, and then people will do better, hopefully. So this is brilliant data, and as a guiding medical oncologist, this is the best data we ever saw, and probably will ever see. A separation, when you're at a scientific conference, I say, if you can't see the separation of the curves at the back of the room, there probably isn't a difference between them, even if it's statistically significant, right? See how big the difference between those curves are. There's no doubt, no doubt, right? The problem from this point of view, or from my point of view, if you look at this, great, 50% are disease-free at 5 years. But what about the other 50%? Why doesn't it work for everybody? BRCA-associated ovarian cancers are uniquely sensitive to PARP inhibitors biologically. So why do some of them grow beyond our PARP inhibitor? Why does the PARP inhibitor not suppress for some of them? So we have to learn this too, right? So I don't expect you to kind of drill into this slide, but one side is looking at mechanisms of resistance to PARP inhibitors. We will understand this better. There's a lot of research in this space. And then the other side is if you pair drugs together. So sometimes what happens is if you block a vulnerability in the pathway, they find an escape route, right? They find a way around. But if you give 2 drugs and you get rid of the escape route, well, that might solve that problem. And we will definitely fix this over time. We just haven't done it yet. There's a lot of work going on in this space, so I think there's a lot of progress to be made. Some of all of this will help us understand the cancers better. Some of what we will learn from this, from resistance to PARP inhibitors, will help us understand prostate cancer biology better. And there's a lot to be done there. So of course, for someone who has a cancer diagnosis, the focus always is on the cancer they have and putting that behind them. However, if we achieve that, well, then we focus on their future cancer risk as well, right? So if you look at this data, say we have these PARP inhibitors in ovarian cancer, we used to kind of historically say in ovarian cancer, well, the ovarian cancer unfortunately is a challenging disease. So let's see what happens from that point. Well, now if you say to a woman, if you have your PARP inhibitor for 2 years, you get to 5 years, well, then we really need to refocus on the breast cancer risk again. For the initial period after ovarian cancer diagnosis and your chemotherapy, breast cancer risk actually goes down to something akin to the general population risk, not because of the therapy. But as you get away from that time, then we're back into a higher risk cell and we need to think about it again. And of course, in breast cancer, it's slightly different to ovarian cancer. Although breast cancer is very challenging for individuals, and for individual patients, they may require therapy, and unfortunately not everyone is cured of breast cancer. But if you take the masses, the overall outcomes from breast cancer in the general or the population of breast cancer are actually very good. And that's why this is such a key opportunity, because if you have a breast cancer diagnosis and you're eligible for genetic testing and you have your BRCA pathogen variant identified, well, then you can prevent your ovarian cancer for you and for the other people in your family, right? So this is where we talk about the future risk for the cancer patient themselves. And if that's depending on the outcome of their current cancer, that might be very important in terms of reducing future events. And then in terms of their family members. And of course, cascade testing or predictive testing is where we can really make good progress. So the idea is if you test all women with ovarian cancer or selected women with breast cancer, depending on age and family history, well then test their family members, then you can have risk interventions. These are our current risk interventions, but obviously they'll hopefully change in the future. And this is a really interesting study where they looked at, in the United States, they reckon it's about 4 million people who have a high risk cancer predisposition gene. So if you wanted to find all 4 million of them, it could take you about 50 years if you test 10% of their first, second, and third degree relatives. But if you test 70% of them instead of 10% of them, well, then you'll get there in 10 years. That's not that long. So you could find all of these people in a relatively short period of time. Now, obviously, there's huge resource implications, etc. But this gets me back to the encouraging the right person in the family to test. If you test the right people, the yield from that is very high. Sometimes, unfortunately, the right person isn't willing to test, and we do test other people. But you can't necessarily reassure families on the basis of testing the person who's not highest risk. There are opportunities to make things better from that point of view as well. We're missing another slide here.
It's not my fault.
No, this is my fault. I haven't sent you the wrong version. But they did a study anyway. Ken afterwards, who I used to work with in the US, he did a study for Ashkenazi Jewish people. It's called the Peace 4 study. They did the pre-test education with chatbots and videos. I was so impressed with the chatbots. So basically, people had their pre-test education done without going to a genetic service. And then they went to genetic service if they had pathogenic variant identified. And they managed to enroll 5,000 people and test about 4,000 people in just over 2 years. Like, we have a huge waiting list in St. James's, and we do not have the staff to deal with it and trying to be creative with it and different things, but it just shows you what the potential for the future is. But it was also going to do, and I don't think it's done it just yet, though, is that if you've got a BRCA pathogenic variant, it's not just giving you a letter to go home and tell your family that you would have their phone numbers would get sent a link, and then they could just take that link into another education thing and take it on from there. That stuff seems like it's somewhat fantastical right now, but it really isn't. Like, in 5 to 10 years, it'd be so much easier to achieve all of these things. And the huge capacity for AI and things, scary as it is in some ways, but to do so much in this space. So I think this will all get a lot easier. And then just a very final slide on reproductive decision making. So this is from Ken, actually, an editorial in 2006, a while ago, when really pre-implantation genetic diagnosis. So that means doing full IVF and selecting embryos that do not carry a pathogenic variant. It's really done more commonly for childhood disorders. And then in around this time, they started doing it for adult cancer syndromes potentially. And we used to do a lot of this in the United States, actually, when I was there. It does take full IVF, which is the emotional and financial cost of that, which is huge. So all IVF in the United States is done in a private way. Not everyone has insurance coverage for it. It costs about 30,000 a cycle. It costs about 10,000 a cycle here. I used to say to people when we were counselling for this is, if you had a child born tomorrow, you're talking about their risk in 25 to 30 years' time. So I do expect the world to be different then, and that may affect how you feel about this. But there are some people who feel very strongly about what they've been through personally, what they've been through in their family, and they really just do not want that for the next generation. And so they go through this pre-implantation genetics. And the other thing is sometimes people do, if you don't have any offspring with embryos, if all your embryos have pathogenic variants, sometimes they select males. So that's an option. I suppose it gives people some agency or some choice. That's not how everybody feels, but to have options can be empowering, even if you don't want to do it. So what I just wanted to say then is thank you very much. I think there is a lot of good work that has happened. There's a lot of progress in this space, and hopefully into the future, things will be radically different. Fingers crossed. Thank you.
I think a lot of keys, powerful, personalized, potential. Yes. Yeah, I think it's great, very promising for the future. So yeah, thank you so much. Are you all hanging in there? That work was all up, didn't it? Yeah. Did you hear that, Karen? The work was all up. Fantastic. I could listen to you all day. Yeah. Oh, sorry. I'm calling Bernie. Somebody's calling Bernie. Bernie,
can I ask Karen a question?
oh, sorry.
I'm
going to put up your brain up.
Yes. Because of potential complications Don't recommend the other. Is there a difference here or is it the same? This is future.
Yeah.
She said it wouldn't recommend taking
Yes.
unless there was, when you took out the choose, where three changes in the choose.
So sorry.
I'm sorry, they wouldn't recommend taking out the uterus.
Yeah.
Okay, we're almost coming to the end of our day. I think people will be full to the brim of information after such a long session this morning. So my name is Liz Yates, I'm the CEO of the Marie Keating Foundation. So it's up to me to wrap up proceedings today. I think we've had a huge amount of information today, a lot to take in. We are so fortunate to have such an amazing lineup of expert speakers from different aspects of the healthcare system, and particularly experts in the BRCA field. It's ironic, I was just thinking today, it's 7 years ago since Dr. Eoin Salmon actually at this very hotel location asked to meet with Helen and myself, and she and another patient advocate, Roisin Prizeman, who is a BRCA carrier, basically came to us and said, please, can you do something at the Marie Keating Foundation for the BRCA community, because there was nothing in Ireland. And Helen and I at the time were saying, well, you know, we're a small organisation, we're very limited funding, we don't get government funding, we'd love to, but how can we do that? But we promised to set up one initial seminar and to see where we went. And that was 7 years ago. Here we are 6 years later. And I'm so very proud that we've actually been able to embrace the BRCA community. We've been able to set up a number of services which I think have really made a difference. I mean, even looking back at the 6 years of the different seminars that we've held, the different topics, be it genetic testing, be it communicating to family members about how to break the fact that you have a BRCA status or a positive BRCA gene, looking at risk-reducing surgery, both for breast or for ovaries, bringing in the different surgeons. We also hold our BRA Day every October, which is the Breast Reconstruction Awareness Day, looking at the new methodologies for breast reconstruction and risk-reducing surgeries, and we'll be holding that again this year. So just want to say we're in line with the Marie Keating Foundation's commitment to be with the cancer community at every step. Just to say that is as valid for the BRCA community. We've come a long way in 6 years, and I was just so encouraged and kind of reassured by a lot of the positivity of today. Like when we look back 7 years ago, there was no strategy in place. There was very little being done from the government or the HSE. There were very disparate services. Genetic testing was really, really difficult to access. There's a lot more to be done, but we've come a very long way, and really encouraged particularly by Trina McCarthy's presentation this morning, launching a new strategy, a new roadmap. The fact that healthcare professionals are now being educated and trained to support the BRCA community and other genetic cancers. So a lot more to be done, as Bertie Ahern would say, but we've come a long way. So just a number of thank yous. So first of all, to all our experts, because I think most of them have gone today because they're such busy people, but you know, all of today's proceedings were recorded. So I know it was a lot to take in. So please feel free, once the recording is back on our website again, you can look at it again, or you can share it amongst your family members and with others as well. So I would like also to thank Astra Zeneca and MSD, who are our sponsors and have been pretty much since the beginning. They've stood with us, and delighted to have Thomas and Adele here representing AstraZeneca today. And thank you for your support. We really would not have been able to put these seminars on without your help. And it just makes such a difference. So thank you again. To all of the peer-to-peer supporters and our panelists who spoke today, I think your stories really allow all of us to put ourselves in your shoes and to know what it's like to be talking to a daughter or a son, a brother or a sibling about your BRCA status. I mean, I'm a cancer survivor, but not, you know, and it's another whole dimension knowing that there's a genetic cancer in your family and how you should go about that and how you deal with that, how you seek help with that. And again, very proud of the different services that the Marie Keating Foundation has established since the first seminar. So we have the peer-to-peer helpline, and huge thanks to all the volunteers who have put themselves forward to help others who are newly diagnosed. We also have the regular meetings, online meetings. So I think the next one is actually on the 8th of May, sorry, the 4th, next Thursday, the 4th of May at 6 p.m. So details about that are on our website. And please tell your friends and family about those services. Finally, I'd like to thank the Marie Keating Foundation team. So Jenny and Fiona, Jane, who's done a huge amount behind the scenes and pulling all the technology together. Jonathan, thank you very much for your help as well in organising the tech today. To our nursing team in particular, I know Melanie's here, but Helen, our Director of Services, but most and foremost to Bernie, who is leading, as she said, on our BRCA services and who led today's proceedings. We are so fortunate to have such an amazing team at the Marie Keating Foundation. And Bernie, thank you so much for putting all the preparation into today. And last, and Fiona, I didn't thank you for helping behind the scenes and for coordinating all our online activity as well. So huge thanks to everybody. And last but not least, to thank all of you for coming along as well. I mean, I think information is power, and particularly when it comes to BRCA and it comes to that important decision making, I think the more you can inform yourself, the more empowered you will be, and going forward, hopefully make those right decisions. And I was really struck by Marlia's quote from her mum, who said, "You make the best decisions you can with the information you have at that time." And like, you are going out of your way to inform yourselves better, to know what services are available, where you can seek help. So those decisions will support you in talking to your family members and hopefully making those decisions that will suit you best. So without further ado, just a couple of housekeeping things. Everybody will get a parking ticket. I think Fiona might have them up.
Yeah,
Or Linda, sorry, and Jane has them at the back of the room. Sorry, Jenny has them there. So anybody who is parked below, you can get your free parking ticket. As I said, the recording will be on our website. And we will be doing an evaluation of today. So anybody who had registered with us will be getting an email with a request to fill out an evaluation form. And please give us your feedback. It's really important that we know for next year's seminar and for even our online meetings as well, what other topics you'd like to hear about, other experts you'd like us to invite. And so that feedback is really important. I know a few people have said that they would love to have it on a Saturday maybe, because family members are involved at work or whatever. So we'll do our best to take on board your feedback and improve as we go along. So I'd also just like to say one thing, I know Tara and Lisa, who spoke so well, thank you so much for your input. Tara and Lisa are also ambassadors of the 100K in 30 Days Challenge, and the Marie Keating Foundation has been selected from this year as the charity partner for that challenge, which is for our breast cancer services. And it is to run throughout the whole month of June. And we would love if you might be willing or interested in joining us and signing up for that challenge. It can be 100 stand steps, it can be 100 run, or if you're running or jogging or swimming or any exercise at all throughout the month of June, we'd love. Linda's down there in the t-shirt. You can sign up outside at the desk. There's a QR code, but it's been launched on Monday, so you'll be hearing about it between now and the end of May, and we'll all be getting involved in that. We're also going to be at Bloom on the June bank holiday weekend. We'd love to see you there. The theme will be catching cancer early, so just to let you know about that. So without further ado, I hope you all have a gorgeous weekend. Helen's going to, I think, guide us to calm down after hearing so much information today. So thank you again for coming, and wish you well, and wish you a lovely weekend.
I'm not going to do visualization or relaxation, you'll be happy to know, but my job here today really is to set us out on homeward bound with positivity and hope. Okay, so we've had a tough day today, and BRCA in the eye of the beholder is what it is, isn't it? You all know what that feels like. But I guess, it's difficult in thought, isn't it, and in emotion. There's a lot of emotion attached to a BRCA diagnosis. So we want to embrace that too. We want to embrace what happens to you in the room here as individuals. And we know our peer supporters are so valuable to us. And I suppose the first thing I'm going to do is invite Jane up to light a candle. And that candle is really to acknowledge what happens in the room. And it's to remember and honor loved ones who are no longer with us today. And it's to symbolize hope, healing, and remembering. So with that, I'm going to recite a poem, and I think this will resonate with every one of you in the room. I quite like it, I hope you do. And it's from Stephanie P. Henry. Sometimes, most times, life is going to throw something at you when you're not looking, and it's going to hit you straight in the face without warning. It will knock you down, take your heart and break it into pieces. And when that happens, you're going to scream, cry, swear at the sky and other things, and ask why, and that's okay. Then you're going to get up, you're always going to get up and start again, because you will learn that staying down means giving up part of yourself. And rising back up is you, gathering your pieces, claiming your crown and saying, there's more where that came from, try me now. Okay, so I think that resonates with a lot of you in the room, doesn't it? It's what you have to go through. But the other thing I really want you to leave with today is kind of on any ordinary day, you can remember that hope is in your way, okay? And I've done this before where we just symbolize things that happen in our everyday life. And that makes us remember to think about hope. So when you see a bright star, this is to remind you to keep smiling. A paper clip to help you hold things together. A feather to lighten your load, and cotton wool to soften life's blows. Love hearts knowing that you will get through, and a smiley face knowing that happy times are ahead for you. A peg to help you hang in there, a tea bag, because we know that where there's tea, there's always hope. And the candles that are lit here today, believing that on your homeward journey, there is light at the end of your tunnel for you and for your family. So I invite you all to come up and maybe just take a look in the mirror, what I call the mirror reflection. Look at yourself and think about the hope that you want to bring to you and your family, and the symbols are on the table to do that. So it's probably just a nice gesture for you to do and to remember. And every time you hang up your clothes on the line, hang in there. So it's the simplicity of life, isn't it? I know Lisa talked earlier on about simplicity. I love simplicity myself. So if you're hanging out the clothes, or if you're putting a paper clip on something, just remember it's a symbol of hope. You need to keep it together and to hang in there. So thank you so much for today. I know you're all very tired, but I do wish you and the whole team from the Ricky Foundation wish you a safe journey home. And it's all women in the room apart from Jonathan there, isn't it? There's one man down there. Okay, so yeah, I would like you to come and maybe put a symbol on the mirror of reflection and yeah, and then take it from there.